You're listening to Who's Tom and Dick, a weekly podcast with your hosts, Martin Weavers, fighting stage 4 lung cancer, and Patrick Mortimer, living with heart disease. Why not grab yourself a cup of coffee, sit back, and enjoy the chatter as we discuss and share information, talking about tough subjects, and offering help, support, and motivation with a positive mental attitude.
Well, good morning, Patrick. How are you?
Good morning, Martin.
Are you good?
Yes.
Yeah.
I'm impressed with our settings today.
I do take you to some of the nicest places, don't I?
Yeah.
It's grade 1.
Grade 1 listed building, and some of the beam and woodwork in here is incredible.
Yeah, and we just had another look at part of the house, so we're here to interview one of the top urologists in the country.
Yes.
Yeah. Well, he's now retired, and we want to introduce you to Chris Booth.
Good morning, Chris.
Good morning.
Good morning, good morning.
Welcome to Who's Tom and Dick, and thanks for taking part.
Yeah.
You're very welcome.
Now, we know you're obviously retired.
Yeah.
And but what we like to do is get to know our guests by you telling us exactly, how you started, why you wanted to be a urologist.
Well, certainly, and thank you very much for asking me to. Well, we are in what is my family home.
Yes.
My parents moved in here into cottage next door in 1943 during the war. I was born in 1946. In fact, I'm in that pram in the painting.
Oh,
there.
wow.
And then in 1953, Dad bought this house and the attached cottages and started restoring them as a hobby, really. So I was born and brought up in the country, and I think because of that, I rapidly acquired a love of the outdoors, nature, birds and bees. I was similarly encouraged when I went to school, and finally I wound up as the secretary of our Natural History Society when I was at Felsted. And during that time, I did zoology as one of my A-level courses alongside the physics and the chemistry and so on, and became interested in dissecting things. And I started up sort of amateur taxidermy.
Oh.
So I'd got skeletons of dogs and foxes and rabbits and things. And so I thought, well, I'm either going to be a vet or going to be a surgeon. And I thought I like people, so I went into surgery.
Mm-hmm.
Didn't know what sort of surgery, but certainly from the age of 16, I wanted to do surgery. I went up to St Bartholomew's Hospital in London. That was my training school, Barts as it's usually known.
Yeah.
I got in there because I was able to play rugger, I think. That was the first requirement.
Yeah.
But of course I got my A-levels. And from then on, really, everything was aimed at passing the exams and starting in surgery. You have to do a bit of medical training as well. So my first job, in fact, as a medical house officer, as soon as I'd qualified, was at the Dreadnought Seamen's Hospital in Greenwich. It's now closed down, but it was a marvellous place. We just had 2 medical wards, largely filled up by merchant navy sailors. So I learned all the general medicine and got a quick grounding in venereology, skin diseases, and tropical medicine, and all about the parasites and worms and various things like that. And it was a really good job to do. But then from then on, it was all surgical training. And my first job down here was at Colchester General Hospital. After 6 weeks of training under the registrar, you're taught how to do an appendix, appendicectomy, and then you're on your own. So you start diagnosing people coming into casualty with what you think is appendicitis, taking them to the operating theatre and operating on them. And it worked out more or less that once one had the basic training how to do an appendicectomy, every night you were on call, you did an appendix.
Yeah.
And sometimes it wasn't an appendix and you would find something else and you'd have to ring up and say, can you come in and help? I found this girl's got an ectopic pregnancy, that kind of thing.
Yeah.
Because we didn't have ultrasound or anything in those days. You did it all by taking a history and a physical examination of the patient and basic blood tests and so on, and then into surgery. I wish it was like that now, because the surgeons now don't get that sort of training, which is a bit worrying. Now that I might need them. So, having started on the surgical route, not with any particular idea what sort of surgery, you start rotating around, doing various jobs, 6 months here, 6 months there, then you get a senior house officer's job, start moving on to more complex operations. Then you start thinking, right, okay, we need to start looking at specialists or specialisms, and one of those, after I'd done my casualty house officer job, which is again part of the necessary training, and a very good one, I was directed down to Black Notley Hospital, as it was.
Oh God, yeah, I remember
in those days. It was a regional orthopedic centre, and I felt that if you're going to be a general surgeon, then you needed to have some basic orthopedic knowledge, especially when dealing with multiple trauma, that kind of thing. So I came down to Black Notley, but I discovered that there was a job that was half general orthopedics and half of it was plastic surgery. And I thought, that's good, that's really good. And I got that job, and that first sort of fired my interest in plastic surgery.
Your posts have been quite local, haven't they, with Colchester and Black Notley? So
Well, they were. I also worked in Romford and back in London, in Whitechapel. That's where I did my casualty training. I subsequently went back there as a registrar, which is the middle grade. This was a senior house officer job in plastics and orthopedics at Black Notley, where coincidentally I met this Irish girl who made you a cup of tea earlier on.
Yes, I was going to say, I think we know where we're going there.
That's right. I crashed what was her 21st birthday party on New Year's Eve. I didn't even know it was her birthday. I'd only just arrived in the hospital. I just thought it was a hospital party. It turned out it was her 21st birthday party. So that's where that started. But that fired an interest in plastic surgery. I needed to do more general surgery, so I got a job back at the London hospital, rotating through orthopedics again, urology, thoracic surgery. And then I thought, I'm not going to be able to get back to Colchester as a plastic surgeon, because there's never going to be a plastic surgery unit in Colchester. And I'd always wanted to come back here. The house, I'd worked obviously in Colchester General Hospital. I felt a great esprit de corps amongst the general surgeons, and I thought it was a really good training centre. At the same time, obviously, I was exposed to urology, working in the professorial urology unit, and I saw that urology was going to explode, because at that time, all the urology was done by general surgeons. A third of what used to be called general surgery is actually urology, but there was a tremendous explosion of technology in the mid to late 70s. We developed so-called rod lens systems that let us see properly, up telescopes into the bladder and see properly for the first time. We weren't relying on sort of little Mickey Mouse electric bulbs that used to glow all the time. We got fiber optics in, which meant that we could put a fiber optic telescope, flexible telescope, all the way up the willy. That, of course, is the professional name for the penis. All the way up the willy, through the bladder, into the ureter, and all the way up to the kidney.
Wow.
This technology was developing, and I thought, another thing that was developing, of course, was ultrasound. We could break up stones using focused ultrasound, focus it onto a stone in the kidney, and literally break it up into grains of sand. We were going directly into kidneys with telescopes, not up the willy and up the ureter, but directly in through the loin. So all of this was developing at the time that I got my first specialist urology job at the Institute of Urology in London, and subsequently at the Middlesex Hospital, I was very lucky, I was working for top professors in the trade, as it were, and at the Institute of Urology was seeing all of them, doing all sorts of different things, learning, and I was learning what I could do, but equally learning what would not be suitable in a district general hospital. Going to Great Ormond Street, I did 6 months in one of the satellite hospitals from Great Ormond Street, Bethnal Green Children's Hospital. I think that's closed down now, but we were doing tremendous surgery there. And of course, you can't do that in a district general hospital. So you're learning what you can do, what you can't do. And then the final leg of training, I was doing urological research on bladder function at the time when we were really discovering how the bladder worked. We were measuring pressures inside the bladder, measuring flow rates, doing video on it, something called video cystography, adding in the pressures. So for the first time, we saw really why ladies were leaking, all sorts of causes for that, and why men were getting blocked up and having problems with their prostate and bladder neck obstruction and all these various different conditions which we were seeing for the first time. So I was doing some of the best available research at the time, but I needed to get the final training ticket, what's called a senior registrar job, and one came up in Dublin. Dublin is on the British Isles rotation, along with the 2 Scottish colleges and the London College. And I asked a friend at the Institute of Urology, he subsequently became Professor of Urology in Dublin. And John said, "What do you want to do?" And I said, "Well, I want to start a specialist urology unit at Colchester General Hospital." And he said, "Well, you won't get finer training than the Dublin job, because you'll work in 3 different teaching hospitals, you work for 10 different consultants, you'll see the lot, including things like renal transplantation and so on." So I applied for the job, not thinking for a minute that I would get it. I thought there's bound to be some local Irishman. I was going to say Paddy then, but some local Paddy who'll come back from America or whatever. But I got the job, and it was tremendous. Compared with London, the training was certainly varied. There were some very good bits. There were some iffy bits compared with London, but I have to say that the golf was very good, and the horse riding over there is arguably the best in the world.
Right.
So that's where I completed my training and got my ticket.
Yeah.
Chris, you've mentioned that your career has continued with the development and explosion of improvements and equipment in the sector, and that continues today. What do you think about remote surgery?
Yes, funny enough, I was in a society called the Society of Minimally Invasive Treatment, and one of the things that we were developing at the time was, as I mentioned, doing things with telescopes. So you put the telescope in, because we're used to using a telescope and operating up it as well, we were, if you like, the first keyhole surgeons. It all stemmed from the urological instruments that we were using.
Right.
And I can remember going to a conference in Dublin in the late 80s, where for the first time we were talking about using a console to operate, and a guy could be sitting in a console, using the console in London, whilst a robot would be operating in Philadelphia or New York or somewhere like that.
Yeah.
Because you could set the robot up to do the operation. So the way it developed was, first of all, we were putting our instruments into the abdomen manually, but you're watching, instead of looking direct, you're watching what you're doing with a monitor.
Yeah.
Because instead of using your eyeball to see something which is 2 to 3 feet away, using a long instrument which with your tremor is going to be trembling even more at the end.
Yeah.
Okay, there's not much of a tremor, but there always is. And your target organ, maybe you're doing something very delicate, is going to be 2 to 3 feet from, 18 inches away from your hand and 2 to 3 feet away from your eye. If you can put your camera on the end of that instrument, you're now only inches away from your target organ.
Yeah.
If you then connect your surgical instrument to a robot doesn't have a tremor. So all of a sudden you can do very, very much finer, more detailed operating by using a robot.
All right.
So that's how it developed. And for a long time, there was really no difference in the outcome between what was known as laparoscopic surgery, where you're holding the instruments, and robotic surgery. But as the robots improved and the timing of operations got shorter and shorter, there's no doubt now that robots basically are better.
Yeah.
And less skilled surgeons can use robots.
Okay.
And the robot, I think, will make up for human deficiencies. Robots don't get tired either.
Yeah.
Yeah.
Which is a factor.
That's an interesting response, because I was wondering whether you'd have sort of a negative response to robots, being that you've come up through the ranks from the 1940s, 1950s.
Yeah.
Traditional.
Well,
So it's very interesting to hear that.
you always, yes. And I think I've seen that transition. I got to the stage where I was doing, for instance, in my speciality, radical prostatectomy. Now, removal of the bladder has always been something that urologists have done. It's a big operation and you replumb things and so on. Removing a prostate in its entirety is much trickier because it's right at the very bottom of the pelvis. So you are literally, your eyeball is literally 3 feet away from what you're trying to operate on. And when you remove just a prostate, you've then got to reconnect the bladder to the base of the willy, where the muscles are, tiny little muscles that keep you dry.
Yeah.
And obviously, if you damage those muscles, you wind up with an incontinent patient. The other big problem, of course, is the nerves to the willy are running on the surface of the prostate gland. So if you whip out the prostate and the fat round it, you take the nerves out, so that a man will automatically develop erectile dysfunction.
Yeah.
So those were the two big complications. Thanks to the work of an American urologist, followed by the introduction of robotic surgery, laparoscopic surgery, and these telescopes now right down there on the organ you're operating on, you can see where the nerves are. You can separate the nerves from the prostate, and you can do so-called nerve-sparing prostatectomies. You can also make sure that you don't damage the external sphincter. So the complication rate from radical prostatectomy has reduced very significantly, and that operation, until we find some magical drug or some other magical way of knocking out early prostate cancers, that's going to be the curative operation for prostate cancer for some time.
Yeah.
We're developing further minimally invasive treatments such as high-intensity focused ultrasound, where we can paint out little bits of cancer, cryotherapy, where we can knock out a single spot of cancer within the prostate. But until these are proven to be as good as radical prostatectomy or radical radiotherapy,
Yeah.
they've both got equally good cure rates. They've got different spectrum of complications, but they've got equally good cure rates. Until these minimally invasive treatments have proven themselves, we know that they cause less side effects, but we want to make sure that they're just as good in a curative sense. So that's where we are with this type of surgery, and that's how it's developed from, if you like, robotics and better illumination and better vision.
Yeah.
Perhaps for our listeners, could you tell us what the prostate is actually for in the body?
Yeah, it's a small organ. It's about the size of a walnut in young men. It's located immediately below the bladder. Pipe from the bladder runs right through the middle of it before going into the urethra. That's the name of the tube down the willy.
Mm-hmm.
And ourselves and dogs have the misfortune of having the prostate gland wrapped around the urethra. All other animals have got their prostate glands sort of off to the side. Yeah. Because it's wrapped around the urethra, as the prostate enlarges, that pipe often gets blocked off. So that gives rise to urological problems, urinary symptoms in men as they get older. And of course, there's cancer in it. But the role of the prostate is to provide fluids that help sperm swim, provide an energy source. It provides proteins which liquefy semen so that sperm can swim better. There are hormones that will help to dilate the cervix and so on, and say, come on in, boys. So that's the role. It's a sex gland, essentially.
Ah, right. And what are the first signs that a man might have of cancer with the prostate?
Well, early prostate cancer doesn't cause any symptoms or signs. It's silent. And it's only when the cancer has become considerably enlarged and is then impinging on other organs such as the bladder above or the rectum behind that it produces any physical signs. Mm. When it starts to block the urethra, then of course it causes exactly the same symptoms that men get as they get benign enlargement of the prostate, which is slowing up of the urinary stream, having to stand and wait for the urine to start to flow, dribbling afterwards when you think you've finished and then the urine dribbles again. It also upsets the control mechanism of the bladder such that you have to pee more frequently. That probably doesn't matter much during the day, but if you're getting up 2, 3, 4 times a night, having your sleep interrupted, that's frequently the symptom that drives people or men to the doctor. Blood in the urine is always a worry. It's not. It quite often comes from the prostate. Similarly, blood in the semen. Usually blood in the semen is harmless, but occasionally it can be a sign of prostate cancer. Those are the sort of typical symptoms. They're the same symptoms that you get with benign enlargement of the prostate. So most of the men who develop these symptoms have not got cancer. They've actually got benign enlargement. But a lot of men think that it might be due to cancer. In fact, one of the problems that we have at the moment is because early prostate cancer, early meaning that it's inside the gland, meaning also that we can cure it with radical surgery, radical radiotherapy, or some of these new minimally invasive treatments, and they're certainly not suitable if the cancer's got out. With early prostate cancer, there are no symptoms, and that's when you need to be screened. And it's very irritating that lots of men go to their GP saying, can I have this PSA blood test, please? And the GP says, no, go away, come back when you've got symptoms, which completely the wrong advice. They'll also tell you, a lot of GPs will also tell you that PSA is an inaccurate blood test. It's not an inaccurate blood test, it's the interpretation which is problematical. It's a very accurate blood test, but it isn't specific for cancer.
Yeah.
So if you have an abnormal PSA, it doesn't necessarily mean you've got cancer. In fact, if you have an abnormal PSA, you've a 3 out of 4 chance it's due to something harmless, such as benign enlargement of the prostate or inflammation in the prostate. But a 1 in 4 chance it is due to cancer. And with a 1 in 4 chance, you're not going to sit on it if you've got a 1 in 4 chance. You go on to the next investigation, which is an MRI scan of the prostate. An MRI is extremely accurate and will tell you if you have, or equally important, if you've not got prostate cancer. So that's the diagnostic process.
Yeah. So do you think nowadays that apart from an operation, there's better medication. And the reason why I asked this, I went on holiday last week and heard these old boys, and they were saying, Joe, I've got these new tablets. He said, I used to get up 4 times a night. He said, I'm only getting up once now. And the other old boys, I still get up 3 times. But so do you think the medication is better, apart from an operation?
It all depends. For severe prostatic symptoms and severe obstruction, surgery is the answer. For mild to moderate symptoms, I mean, if your symptoms are mild and they're not bothering you, you don't really need to do anything about it. You just need to be aware of such things like, if you want to go to the loo, don't hang around. Go to the loo, don't hang on, because you might have an accident if you don't go, sort of thing. But if you've got mild to moderate symptoms, then drugs are definitely the answer. There are 2 sorts of drugs. There are drugs that relax the muscles around and inside the prostate, and they'll improve your flow and usually decrease the frequency and the urgency. In fact, actually, there are 3 types of drugs now that we use. The other mainstay drug is one that's designed to shrink the prostate. And it's a very clever drug because we all know that men rely on testosterone to make them men. Well, the prostate gland requires testosterone to grow. But what happens inside the prostate is that there's a little enzyme called 5-alpha reductase, and that converts testosterone, raw testosterone, to what we call dihydrotestosterone, which is what the prostate uses to grow and keep itself healthy.
Right, yeah.
So you can take this tablet. It doesn't really have any side effects because it only works inside the prostate, and it prevents the prostate from growing because you're starving it of its necessary hormone. So if you use one or other drug, they will usually help. But if you use both in combination, the result is even better. And if you're using them both in combination, then over many years, they'll reduce your risk of developing complications due to prostatic obstruction or the need for surgery by a half. So they're very good drugs.
Well, thanks very much for that, Chris. I'm going to stop you there, and we're going to record part 2 of this great conversation. What do you think of that, Martin?
That was fantastic. Thank you very much, Chris. Really kind of you to give your time up, and we know how valuable it is to you, what you're going through now, and we're going to talk about that another time, aren't we?
Yeah. So for this week, next week, we're going to have part 2, which will be concentrating on Chris's subject of speciality, which is prostate cancer.
Yep. Thanks very much, Chris.
Thanks for listening, everybody. And we'll be back same time, same place next week.
See you, folks.
Have a lovely weekend.
Yes, and a lovely week.
Yep. Bye.
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 You've been listening to the Who's Tom and Dick podcast with your hosts, Martin Weavers and Patrick Mortimer. If you enjoyed this episode, please subscribe to the show on Apple, Spotify, or your favorite streaming platform. New episodes are available every Friday. Thanks for tuning in.